we're looking at about 3 questions, and we'll see how that goes. So the first one, it's a bit of a long question, so bear with me. And it's, if part of the issue that we're facing really is about the government saving money, how can the system be transformed so that the government need not resort to MAiD in order to do so? For example, could we insist that the wait period for MAiD must equal the wait period for treatment for that given illness? Might that help with this, financial claim? And I'll put that out to both of you. Sorry for putting you on the spot. And if either of you have any comments on that.
I'm always happy to comment on anything. Sephora, would you like to go ahead?
I can say a few words. So, I mean, both Dr. Maher and I had mentioned how the services and the social supports that we need are not there. And the result of that is that when patients don't get the care that they need, they actually end up in the emergency departments, hospitals, and that actually costs a lot more than if we were able to just build sort of services in the community that can help to support them living in the community. In regards to having an arbitrary timeline, like you only have to wait until you're able to get treatment, and that would be equivalent to the wait time for MAiD. I'm not sure how well that would work, because sometimes treatment can, like, just to access treatment, there's a wait time there. But then as you're receiving treatment, the length of time that the person may need to actually achieve recovery can vary quite a bit. And sometimes that can take years as well. So I'll turn it over to Dr. Maher now.
Sure. Very quickly, for every $1 million spent on tertiary psychiatric care in Ontario, you save $4 million. So it's not an economic argument that we shouldn't be offering these services. That's frankly false, and has been proven false over and over. These economic analyses have been there for decades, literally. So the economics is nothing. It shows us nothing but stigmatization. These are political decisions not to fund services that we know work and help. The question of tying that to wait times, I'm honestly not sure of the connection. I'll agree with Dr. Tang that the wait times vary so dramatically from person to person. So diagnostic acumen, diagnoses often take a long time to declare themselves and to get to the right treatment, unfortunately. And we have different skill sets, different wait times, different availability, rural to urban centers. There's no single wait time that fits all. And if in an ideal world, we offered all possible services, even if we were doing that, the time it takes to move up the ladder to tertiary care varies so dramatically. You'll have psychiatrists who will follow someone for, say, 5 years, thinking they're just going to get it right by trying different medications, and they might well. So to say they should have referred up at year 1 to the next service level, tertiary care, team-based care, you can't know. You just can't know. This is such an inexact field of care in one respect, but so brilliantly effective when you bring the services to bear. So sorry, the wait time piece, I don't know how you can answer that question. There's no one size fits all. There's not even one size fits many, to be honest.
Thank you both for coming together for that question. And I will move on to the next one, which is, what do you think is the most effective example to give to startle those many people who completely and naively think there's nothing wrong with MAiD, whether that be, a fact or a personal experience you've been through, an anecdote, just something that you would choose as sort of your ideal example to open these people's minds?
So I'm going to boldly go ahead in this one. I can tell you what's going to happen. This is not a fanciful prediction. We are going to have news stories about parents who get a call from the social worker on the MAiD team to discover that their child is dead. And there's no requirement that they have provided information or been involved in the care decisions. There's no requirement that they inform the MAiD team that, hey, they're on a wait list. They've been on a wait list for a year for a service that may help them. There's no requirement that the MAiD team get collateral information. We are going to have family members, this was the case last week, you're free to not tell anybody about your medical care. I get that. That's confidentiality. It's inviolate. It's absolutely protected. But what will that mean when your family member is dead and you didn't know it was coming and you know they were waiting for treatment? To me, that's the scenario that people are going to wake up and say, how is this possible? And the answer, we know the government answer. Mental health care is expensive. Our healthcare system is strained. I'm sorry, it's flat out misrepresentation of the economics. It is stigmatization. I've come to the conclusion there's no other reasonable explanation for denying care to these vulnerable folks. These are human beings, our family members who are suffering. Other than that, there aren't a lot of votes and there's not a lot of power there. I think that's what's going to open a few eyes. But it still begs the question of, will it touch my heart personally? Right? It's not my family. It's not my, and I can't tell you how many times I've heard people say, if they want to kill themselves, why should we stop them? Well, we should stop them because the reasons they want to die are reasons as fellow human beings we can do something about. We stop them for reasons of care, compassion, love, a duty as human beings to respect and support each other. So all of those things fall away. Sorry, they're lost in the rhetoric of cost and the false rhetoric of futility. These are not futile treatments.
Did you want me to add to that?
Do you have anything to add? We'd welcome that.
I mean, I think I kind of alluded to it already as part of my presentation, but just knowing case examples in my own practice of people who would have wanted MAiD, had been deemed sort of hopeless, and then having journeyed with them and watched them recover, and then being able to do something with their life to be able to contribute back to society has been very rewarding for me. And there's no way to be able to predict that was going to happen or how long that was going to happen, but it does happen. And I think it would be a grave injustice to facilitate the suicides of some of these people, knowing that many of them would have been able to recover.
Thank you both very, very much. And our final question for this evening is actually from a psychiatrist and addresses both from the position of the psychiatrist and also from the public in general. So it is, when there is a small but vocal group of psychiatrists who are well connected and have influential positions on committees that are advocating for MAiD, what can we, or you, do as psychiatrists to inject some sanity into the process, and what can we as the public do to do the same?
So my colleagues, my psychiatrist colleagues who are advocating for MAiD for mental illness, I understand their arguments, I understand their positions, but I can't support making a medical clinical decision that is value-based and guesswork, because that violates the standard of care, a duty we all have as physicians, and which begs the question of whether that amounts to malpractice. right? And when you asked about what cases are going to, bring this to people's attention, if I'm a psychiatrist saying this person can't get better, the suffering is irremediable, and they get MAiD, and then there's some legal action, and you have literally the numbers we're seeing on the small sample, potentially 97% of other psychiatrists saying, sorry, I couldn't have made the same determination. What you did, I could not have done. So I'm not sure what to do with that, not just with respect to mental illness, but really any medical care decision. If you're making, this isn't, the Hail Mary pass and let's see what happens with this treatment because maybe it'll work. This is a very different thing. This is irrevocable. It's death. It's I'm going to kill you, and no opportunity for recovery here. So when we have a vocal group expressing what amounts to an ideological rather than a medical or evidence-based position, I think we need to call it that. And it begs the question of what's driving the ideology? Why does this matter so much? And I do think that comes back to the equity versus equality argument. And but we all have our different positions and we all have our different values. So either this is a medical determination or it's not. And the court, at least at this point, is saying it's a medical determination. So that would be my response. I want to engage respectfully in conversation, but you can't reasonably argue against ideology because cogency, logic, reason doesn't persuade or change anyone's mind if they're driven by a feeling rather than evidence. So we have to keep speaking out about the evidence. It's very easy for me to be dismissed by the other side as ideological, right? Because I'm here saying the opposite. It must be ideological. I don't believe anything I've said is ideological. I believe what I'm saying is I've got decades of clinical experience, as do all the other ACT psychiatrists. There's 70 of us in the province. We've been trying to come up with cases where we think the person can't get better. And we have a particular duty, because if not us, if we don't keep trying, nobody does. We're the last resort, right? The other side of that coin is we keep succeeding, and we keep succeeding. The stat is 90% of all people who finally get to an ACT team are no longer admitted to hospital in the following year, when on average, they've had 50 to 100 days each year for years before. We change lives profoundly. And if my psychiatrist colleagues who don't do this work or don't understand the work don't get that, again, I'm not sure what else to say other than please look at the evidence.
Mm-hmm. And I would just say, I agree that we need to be basing our decision-making on evidence, and what is the evidence that you are basing your decision here to offer suicide facilitation. Secondly, as psychiatrists, our role is in suicide prevention. So it's very hard to expect the same professionally. I wouldn't want psychiatrists, I mean, it's already bad enough that medical assistance in dying has been introduced in the House of Medicine. But I think specifically for psychiatrists, where there is an expectation that we prevent suicides, it's a little bit of a paradox to expect the same profession then to facilitate suicides. And then in the same vein, for what can the public do? I think we as healthcare consumers have a right to be able to go to providers who they can be assured is not going to be pushing some kind of ideological agenda, or, as Dr. Maher had said, that those patients who are afraid that their psychiatrist would actually end up helping their son to kill themselves. I think that the public needs to demand that we want to have healthcare professionals who have certain principles and lines that they will not cross in order to feel safe enough to be able to access that care, knowing that they're not going to put death on the table as a potential treatment.
Thank you both. I really like ending the evening with sort of a question that covers what the public or the audience should do, can do. It's I think it always provides a little bit of action after hearing, or hope for action after hearing presentations. So thank you both for that. And just before we close the Q&A, I was wondering if either of you had any final words or thoughts that you were hoping to share this evening. And I'll just open the floor to if either of you have anything in general that you'd like to end with, and if not, I will conclude.
I'm here begging for the people I'm privileged to meet on a daily basis to be cared for, loved, respected, honored, and given the opportunity to heal, recover, and we say have meaningful lives. Each of us should ask ourselves what gives our lives meaning. The abject loneliness and poverty that I see on a daily basis in Canada, we need to be ashamed, I think, of what we're doing. We're offering death. We're saying, on top of all that, I don't think your life is worth living, but I'll help you die.
I totally agree with that. The only reason why I waded into this whole debate was because I wanted to be a voice for my patients who can't really speak for themselves because they don't have a mic in front of them that's going to be projected to lots of people around this country. And I felt I had a certain duty to be able to bring to the spotlight some of the inequities in access to care and the difficulties that our vulnerable patients face. It is very unjust that we have a system now that is going to facilitate death instead of care. I don't think that this is what the majority of Canadians were expecting when they voted for their members of parliament and who are supposed to represent their views. This was all done remarkably quickly, as Dr. Maher had mentioned at the beginning, which is shocking and appalling. I just hope that Canadians will start to wake up to realize what is happening in their country, and just begin to get involved to advocate for the type of really humane care that we would like to see in a country like Canada, in order to bring ourselves back to our senses, so that we build a society where every life is valued.